Thank you, Dr. Pugh. Okay, so over the last day or so, we've had some in-depth discussions around privacy policy and rights, law and regulation, and even a historical context. But today we're going to start talking about IT solutions for privacy. In this session, we're going to focus on research. We're going to talk about the availability of data for research, whether that's consented, non-consented, what are the policy, it's the nexus of policy and technology. So what are the possible IT solutions? What is available now, what is envisioned, and how can it be applied? In this discussion, we'll have various perspectives from those who provide IT solutions, those who are working for organizations, leading organizations who make data available for research, and folks working on national initiatives in that regard. Let's see, Joe's going to be a little late. Let me introduce our speakers. First of all, in the program, you'll see John Wilbanks from Sage Bionetworks. He's not going to be able to make it today, but we will have, other perspectives on technology and its use. So let's start with Dazza Greenwood.
Okay.
Just going in alphabetical order. So Dazza is a lecturer and research scientist at the MIT Media Lab, conducting research projects on big data, identity federation, and trust frameworks. He also is the vice chair of the plenary of the Identity Ecosystem Steering Group of the NSTIC, National Strategies for Trusted Identities in Cyberspace. And Dazza, I'm actually on the healthcare committee, working with Adrian and others for the NSTIC. So I know that project very well. That project is developing a framework for identity and privacy at both the national, U.S. national level and international level. So an ecosystem for online multi-factor, multi-level of assurance identity. He has also testified in DC on the application of these kinds of technologies in various policy situations on the U.S. Senate, the House, NASA, and Department of Homeland Security. So he's also a member of the Stewards Council of Identity Commons, and it heads its forum on law and identity and personal data. And he co-founded the eCitizen Foundation, which focuses on creating citizen-centered online identity and personal data sharing projects and solutions. So he's our identity expert on the panel. Okay. Next we have Marc Natter. Did I say that right? Yes, okay. Marc is a pediatric rheumatologist and researcher in bioinformatics at the Boston Children's Hospital Computational Health and Informatics Program, or CHIP. His research centers broadly on the development and implementation of scalable software solutions and that enable new ways of collecting and sharing research data for chronic disease research. He leads the development of patient-facing technology for the Harvard Medical School's Clinical Data Research Network and coordinates data integration and patient-facing technology for the partner's Patient-Powered Research Network. And finally, Joe Selby. Is that Joe? Hi, come on up. Grand entrance right when I was about to read your bio. So Joe has an esteemed background doing research and writing articles on such topics as quality measurement and improvement in primary care delivery, colorectal screening, and many studies that could be classified under the heading of comparative effectiveness. He has received honors from the Public Health Service, the American Epidemiological Society, Kaiser Permanente, and he was elected into the Institute of Medicine. In 2011, he became the first executive director of the Patient-Centered Outcome Research Institute, or PCORI, and their mandate is to improve quality and relevance of the evidence available to help patients, caregivers, employers, et cetera, to make informed healthcare decisions. So we have a very knowledgeable and esteemed panel who are working on the application of technology for research and also privacy aspects. what I'd like to do, excuse me, is have each person give us their perspective for 5 to 10 minutes, and then we'll open it up for discussion. Okay? We didn't determine an order, so...
Maybe we should do reverse.
Reverse, okay. Let me decide. Let's see.
Being disrupted.
I think maybe Marc. Marc, would you be so kind as to go first with your remarks? And you can come up here or sit there, whatever you prefer.
Sure. I would just ask you to give me the 10-minute warning. Or
Okay. I'd be happy to.
Okay, how's that? Okay, usually I can project pretty well, but yes. So anyway, thank you. So when I appreciate the opportunity to talk, I guess I can start off with an anecdote that I never intended to be in informatics or in information science, although I think my first day in medical school that I was on the floor of my third year, I was convinced that individuals were conspiring against me to just haze the heck out of us. Because the first thing you have to do is collect all the information on your panel of patients that you're supposed to see. And of course, this was a surgery rotation. I show up at 4:45 and I'm already late. This is in the morning because we were supposed to be there at 4:40, and then have to figure out where everything is and how to get the information. And okay, well, obviously there's got to be a book somewhere. I've got a pen and a piece of paper. I'll copy it all down, get a summary. Of course, it's in 4 different places. The medicine's in one place, locked behind, in a room that only the nurses have access to, that I don't. The vital signs are supposed to be on the door of the patient. Of course, you don't know where the patient rooms are by patient name. And so, I finally was like, okay, where's the one place that all this information is? And they're like, that's your job. So that was the quick introduction. To that, I've been fortunate to work with a number of individuals through my fellowship in informatics and afterwards. The very first piece that I'll just talk about to give some history is something called the PCHR. How many people have heard of personal health care records? Probably quite a few. So this PCHR, I'd never heard of that before I came to my fellowship. It's a personally controlled healthcare record. And it's like, well, how's that different? And so the vision really is in the late 1990s, Ken Mandel, Peter Solovich, and Isaac Kohani, and some others, all at MIT at that point, had decided that the future of medical records was a guardian angel function, where you would have a platform that would enable all the information on you to essentially be put in one place, to provide mechanisms where people could view that in a permission fashion, and to allow a sort of benign oversight and analysis and business intelligence, if you will, of your data in a predictive capacity. And so that you can still see, it has one of the 2-letter URLs. It's ga.org, I believe. It might be ga.com, but I believe it's ga.org. It's definitely a 1990s web page. Peter Solovich hasn't changed it yet, but that's a piece of history there that, if you're interested, still exists at this point. It morphed over various years. There was, I believe, either benign disinterest or opposition, or why would we want such a thing, for quite a while. It eventually came to be the Indivo personally controlled healthcare record, and then Indivo X, just because I guess that sounded good too, and it was the next generation of it. The concept there, though, was give patients control, because the hospitals and your various care providers clearly couldn't fulfill the role of actually keeping your records in a way that you could access it. And so this was very innovative for the time. It was actually around 2001 that this started, and it went through various incarnations. The entire focus was that it was role and group based, and you had control over your information. It was a very forward-looking concept, to the point that it was unsuccessful ultimately in its form at that time, because one thing that didn't happen was the liberalizing of getting your records. And so now we're in a much different place, or we'd like to be in a trying, where you can actually get records from various places. This essentially relied on either a hospital buying in and putting some of their records in, or the individual typing in most of their records, which just isn't a feasible strategy for the most part. However, there were some groups that took it up and were very interested. Dazza, made up of Intel, other large groups of employers, made it work and gave their own employees the ability to look at their longitudinal medical record far in advance of many of the things that we're just dreaming of now. And people have probably heard of Google Health and Microsoft Health Vault. Both of those had Indivo as proceeding, and Microsoft Health Vault basically took the API, or the applications programming interface, the language by which one system would talk to another, of that, and then it expanded that. Google Health actually decided this is not an easy area, and they actually got out of it at that point because they couldn't master not the complexity of it, but the fractured nature of the healthcare enterprise at about that point. That's about when I came into it, actually, in my fellowship, and as a pediatric rheumatologist, we have a dearth of information. We see patients, I guess, in terms of providers, when I started, there were about 250 pediatric rheumatologists, including fellows, in all of North America, and we got together in a room about once a year. Now we have about 400, and we get together in a room twice a year. So they're quite few of us, and we're very motivated to try and find out even what the natural course and natural history is for our patients, of which, relatively speaking, there are very few. All patients with pediatric rheumatic diseases make up about all the same amount of kids that have type 1 diabetes. So it's a fairly small number, and when parents come in and ask me, oh, my 2-year-old is going to be put on methotrexate or biologic, what's going to happen in X number of years? The answer up until about 2 years ago or 3 years ago was, well, in my experience here with my colleagues over 25 years of these 4 people, we kind of know this sort of thing, and so we're doing it this way. Not very satisfying for either party at the table. And so one of the things we've looked forward to and are doing now is a very long-term registry and a very consented model for this sort of thing. And so we were fortunate to have a Grand Opportunities Grant around 2009 that allowed us to actually put in what's called a semantic data warehouse. I apologize for people who are not technical, but essentially what it is it's a database with a dictionary embedded in it that computers can read. And so maybe that's interesting, maybe it isn't, but when you want to look at different data sources, it's the difference between going into Home Depot with no signs anywhere and numbered bins and trying to have to look through each to find out what you want, versus the Dewey Decimal System, where you go to the library and you can actually figure out where the books are by looking through an index. This index is machine readable. It had been used extensively at that point for electronic health record data, which was designed to be accessed in a very anonymous fashion. So you would get back aggregate counts only. These were patients who were not consented for any particular research purpose, but the data was available for de-identified analyses. So it allows you to do things like, well, if I want to do study X, do I have 100 patients I might enroll, or are there 10,000 patients? And if you can actually then collect that data across all the hospital systems, and at that point it was all the Harvard hospital systems only, that actually means you could think about doing some real research and be able to justify why you wanted the funding for it as well. So we turned that a bit on its head, and it was a little controversial at that point because we were putting essentially a limited data set or fully identified data except for contact information and patient names, addresses, those sorts of things into this system, and it wasn't really meant to do that by the people who were, who had conceived it for the, shall we say, political purpose of sharing data. One of my mentors, Ken Mandel, had told me that the NIH said that, well, if you can get Harvard-affiliated systems to collaborate, to share data. That's a much harder challenge than anywhere else in the country between other institutions. So they managed to do that, and about half of the effort there was actually legal and contractual. And I found that as an ongoing pattern in what I do, which is trying to free data and make data liquid. And we do this in a consented model because essentially that's the only way in a conventional world that we're able to do this. What our motto is and what we ended up doing with this infrastructure grant for pediatric rheumatology was to actually say we're going to have a club of researchers, and each of the researchers agrees to consent their patients to collect a base amount of data, which is necessary but not sufficient for any particular study. We modularly build upon that, but each institution, each researcher who consents these patients actually has and owns that data themselves. Now, this is very different than the patient owning the data, but again, this was in 2007, 2008. So we didn't have PCORI at that point to help us think about these things, and more importantly, to help advance the overall state of these. And so essentially, we were able to come up with a 60-site network. Each site had their own data warehouse, which we all hosted in one place, but they were all partitioned from each other. Each of the patients was consented by their parents if they were under 18. When they're 18, they would get reconsented for their own usage. And all that initially went onto paper. Ugh. So it was quite painful. Initially, we actually had to put restraints on this such that only the site where the patient was consented could actually look at their contact information. The reason we had to do this was not so much because legally we couldn't, but with 2 years to do a registry and 60 sites, a third of the money went to the lawyers and contractors just to get these in place, and we went through conventional mechanisms for doing so. That brings up some interesting technical considerations. We came up with essentially an NSA, a National Security Agency level database, so that all of these sites could, while maintaining the privacy of these individuals, keep their data, their contact information, in a place centrally. Without having really a central individual or group being able to look at the data. And so, pre-David Snowden, this is the sort of thing that NSA was thinking about but didn't quite put it in all their locations. And so it's quite possible to do this. The lessons we learned from it were that it's really painful to try and debug these systems and do all the quality assurance, those sorts of things. The next generation of this is actually a combination system where patients do consent to allow a central authority, if you will, who's privileged under certain circumstances to actually contact them to maintain the longitudinal nature of the registry. And that's liberalized things somewhat, but the technical underpinnings really of having role-based, cell-by-cell controls on this is very doable, and it takes a slightly different way of thinking about this. So really what I've been talking about up until this point is how do you disseminate data? What's quite important also, and what has come much more to the fore now, is how do you collect data in a consented fashion? How do you put that through a standardized fashion to maximize visibility? Because what we're talking about here, one of the prior speakers' take-home messages for me was that, there's a big business here. The reason they're keeping it private is because that's the way they make a profit. The real value to this is that you're using funding from a company to give them a private view on a very valuable source, and you're adding your own value add to that. A lot of these data sources, even if you could freely share them, are so different that the time you spend trying to sort through it and trying to actually understand what's there is the largest barrier. So one of the things our group has done, and others, and Dr. Gallagher, of course, is actually looking through and coming up with APIs or application programming interfaces that liberalize the exchange of data. One of the projects I'm working on right now is trying to figure out if our data warehouse data in the hospital matches reality, or reality as it is captured in the EHR and by patient report, and it usually it's a bit of an eye-opening experience, partially because of the error-prone way we record things, partially because you have systems that are evolving over 10 years or 20 years, and everyone does it slightly differently. They change this table, they change that table, and there's no underlying standard. It's very difficult even just to compare two data sources when you have things this way. And so the new approach of using sort of human-readable but also machine-readable ways of tagging data and exchanging data, I think, is really the way things are going to go. And then I was just going to talk for a moment about what we're doing now for patient-reported outcomes and platforms. We're actually, through the C3 PRO project at Boston Children's and Harvard Medical School, doing what one of our speakers at Sage BioNetworks is also involved in, and using the Health Kit and Research Kit applications from Apple to very securely transfer data across open networks on the internet, such as Amazon Cloud, those sorts of things, in a very permissioned and secure way. And there's a good amount of technical detail involved in that, which I won't go into, but it certainly I see as the next wave of where we're going. So anyway, thank you very much.
Thank you, Marc. Thank you. Okay.
Does this have the right adapter? Do we know?
I don't know.
Guess we'll find out.
Yeah.
Okay. Oh, HDMI.
Yay.
Good for standards. Oops. Okay. Not sure why it's not. Maybe I'll use my words.
Is there someone in the projection room who can help?
I do, but I don't necessarily need them. I can make the slides available. What I'd mostly like to do is talk. I literally just whip the slides up as primarily as speaker aids for myself. And I'll make them available to the extent people are interested in sites and so forth.